position is actually kind of old. Your book still mentions it too. It's the recovery position. You know, when somebody has some, when they're vomiting a lot, and they tell you to put their face to the side, and they have the recovery position. Because if you have a young infant, and they're laying supine, and they vomit, where's it going? That's right. But if you put them prone with their head to the side and they vomit, where's it going to go? That's right. So it's kind of like that rescue position, but now they're really saying keep them head of the bed elevated. People often ask, why do you want the infant prone? I thought you told us never to put them prone. Just like we told them never to give them aspirin, right? Now I'm contradicting myself again. Well, in this diagnosis, when they're at such a risk for such projectile vomiting, it is better to keep them prone with their head to the side than to keep them supine flat, right? And ideally, they keep them with the head of the bed elevated slightly to, you know. But those are two better options than keeping them supine, obviously, because then they're just going to lay and aspirate. Especially if they don't have good head control yet. That's key. Now, if you have an older infant, really head of the bed elevated is the best, because they have head control too at all. And then nasogastric care, because you will have nasogastric tubes that will help with decompression until you get from surgery. They will go in, they will actually suture that pyloric sphincter, and they'll remove any excess to it. Sometimes, though, you will have swelling of the area after surgery. So you can still have some initial forceful vomiting, even initially, right afterwards. You want to supervise all feedings, document the progress and tolerance of feeds. Go ahead, Stephanie.
So there's no cause, specific cause, just happens?
It runs in families, so really the thing is genetic in nature. You know, it does seem to run in families, but it's not something, again, that's going to happen right at birth, but it's there inside, you know what I'm saying? So it's genetically there. So if the infant does inherit that on the father's side, then they'll display it, usually within a few months of age.
There's no other cause.
Yeah, that's usually what, but sometimes it skips a lot of generations. It's like twins. You know, it skips a couple generations and then it manifests. Gastroesophageal reflux. We had talked again about how an immature cardiac sphincter and immaturity of the nervous system do put infants at risk for gastric reflux or spitting up, and that it is normal, especially in the first year to 2 years of life. Remember we talked about this at the beginning. An infant that is preterm obviously has a higher risk for having this happen. Well, when do we know it's a disease? It's pathologic. So when would I say to myself, okay, I have a young infant who is spitting up and now it's a problem?
What, 2 years?
Well, if they're older than 2 years,
Damage to the esophagus?
okay, if they're starting to have damage, if they're starting to aspirate, or if they're starting to have other symptoms with it too, like you said, damage to the esophagus, blood, or if they're having sometimes symptoms of bradycardia associated with the reflux, respiratory problems, frequent respiratory infections. I've had infants who come in with frequent respiratory infections because they have this, and now it's more pathologic, we have to treat it. Do you see what I'm saying? So most infants, if they're under 2 years of age, we won't treat for this. Like if they have occasional spitting up. But if they're doing it consistently after every meal, and they're doing it longer than 2 hours after the meal, so that means they're spitting up that's not being digested properly then. See what I'm saying? Like they're not going through, it's not flowing well properly. If they're having other signs and symptoms like frequent respiratory infections or heart rate issues, then we have to treat that, and then it becomes GERD. So what usually happens is that they are a good eater, but over time they could have a failure to thrive. Irritability, chronic sore throats, if they're able to tell you. Hunger, spitting up and vomiting beyond an hour, okay? Because that means then there's a problem with it going through the GI tract. Frequent upper respiratory infections, as I mentioned, and even periods of apnea, which can be associated with this. We had an infant actually in clinical who had come in with apnea of prematurity because they had found him unresponsive. And parents got him to respond. They went in, they think they kind of grabbed him right away, and he started breathing. So it was fine, but it was a caught period. And they actually, when they did further testing and everything, they found out that he had a lot of regurgitation, was regurgitating mostly throughout the day. Little bits even, the parents weren't even realizing it, you know? And that was actually going into the lungs and causing problems. And that's why he had this apneic period, because he'd been put to bed and then had this period of apnea. It was right after, actually, they had gotten up to feed him during the night, put him to sleep, and like an hour later they went in just to go check on him. And that's when they found him. And luckily they found him where it was not a sudden infant death situation, which is what happens a lot of times with this too. So those are infants that need to be treated for the gastric regurgitation. So what do to diagnose it? They have stuff like extended esophageal pH monitoring, which actually monitors the pH at the bottom of the esophagus, which should not be acidic. So it's like a litmus paper. And they also do endoscopy to kind of see what's going on in that area. Nutritionally for these infants, you want to make sure, a lot of times they will try to give them smaller, frequent feedings. They'll give them some solid food first and then liquid if they're old enough to be taking in solids. Thickened formulas are very big. Thicket? Anybody ever see that? Adults, they use it for too. It's like they call it, whether they have a pureed diet. You add this, they can use it in children too. They add like a spoonful of it to the formula or to the breast milk, and it will actually thicken the consistency of it. Which, because you know thin liquids, right, are more easily aspirated. So that even if it does not, let me put this, it does not treat the GERD. It just helps decrease the incidence of aspiration. If that makes sense. You know, so you're not really treating the actual problem. You're just kind of helping the fact that older children, they found that have a lot of caffeine products. Again, going back to like I talked at the beginning, Pepsi, soda, things like this. You know, there's not too many children who are drinking coffee, but occasionally we do come across that. Chocolate, things like this will actually increase their incidence.
Mint. Mint is a mint also.
Mint. Yeah, mints. Those are one of the big ones.
I think it's coffee and caffeine and chocolate because of the bialcohol.
Yeah, that's right. Those are really, that actually, it irritates. It's an irritant. Hmm?
Mint has that too.
Yeah, that's what I didn't know, yeah. Really? Okay. Yes, and that is an irritant, that's right. So, I didn't know that about the mint though. That's a good point. Okay, so mint possibly. Bubbling is burping, basically. So it means when you decrease the amount of gas in the stomach, it will actually decrease the likelihood of, obviously, regurgitation and smaller frequent feedings. Positioning. The infant seats, okay, we talked about this actually a little bit, but infant seats put a lot of pressure, those infant seats, okay, on the gastric contents. So again, we want them to be supine, but we don't want them necessarily straight up in those infant seats too. And older children, left side with head in the bed up, like laying on their left side with head in the bed up. Again, that rescue kind of position, in case they do. Other things they give, especially even to infants and older children, Zantac, which what it does is decreases, again, it doesn't stop the regurgitation, but it decreases the acidity that's in the stomach so that when they do regurgitate, it does not cause such a acidic environment in their esophagus. Proton pump inhibitors, the same thing, suppress the gastric. Some of the things like Reglan actually increase how quickly things go through the stomach, which helps. Okay, and then finally, too, they can do surgery. Surgery called a Nissen fundoplication, which actually helps to give some strength, and that's mostly for older children they will do that. So if they still continue to have this into a school age, did you learn about that with adults in GERD? Okay, so that's why we don't do anything in this place in terms of testing, because I know you got that in 132, but older children they would treat the same way they do adults with that, like if they're really severe, that Nissen fundoplication, because it can cause cardiac problems after a time. It can cause respiratory problems, it can cause sleep apnea. I mean, all those things you heard about in adults obviously becomes an issue for children too. Okay, cleft lip and cleft palate. We mentioned these together because they could come up together or they could be separate, okay? Again, a fissure or an opening in the lip or the palate. And this is an infant, a picture of an infant with cleft lip and cleft palate. And they have pictures in your book too. So the cleft palate is the upper palate of the mouth will have an opening in it. Very much, if these infants were not diagnosed in utero, which they can be, but sometimes they're not. Again, going back to prenatal care and going back to how late in the pregnancy they had the actual ultrasound and how good of a visualization they were able to get of the infant's whole face. Sometimes it is not diagnosed. So at birth, your priority really is to have the bonding occur. Now here's where I'm going against myself, right? Because you're going to say to me, didn't you tell us that physical is always more important than having bonding and all that psychosocial stuff, right?
Yes, didn't you tell us that?
Thank you, Stephanie. I knew you would help. Okay, so why am I saying that here then? Anybody have any thoughts for that?
Screw us up on the test. Oh.
Because we don't want
Because
them.
you
Trying to
can't
help
fix it
you.
right away.
You can't fix it right away, and is it really causing them any physiologic problems? they still can breastfeed. Physically, they still gain weight, and they do very well. So you are not doing, they have some nasal regurgitation with the cleft palate and the cleft lip, especially when they both are together. But that does not cause a problem. It does not cause, they have no higher risk of aspiration, you know, especially if they're fed properly. They usually can still learn to latch. Some infants struggle with latching anyway. Do you know what I'm saying? So even without cleft lip and cleft palate. They sometimes will use a breech, what they call a breech feeder, which is one that has a wider nipple, which actually will fill them out better, and it is easier for them to suck, so they can try that too. If it's really a challenge, but they breastfeed fine, they can, many of them do. They eat fine, and physiologically no problems. There are actually children in other countries that don't have this fixed, because they don't have the resources. And they live with cleft lips and cleft palates their whole lives. People, adults, have this.
So Smile Train brings them here for surgery.
That's right. Operation Smile. There's another one too, yes. So, and we see those, right? Those advertisements, the commercials that Melissa's talking about. Yes, Operation Smile. So again, now if you're telling me there's no physical problems with this child, like physically they can still eat, they can still gain weight, they can still, so now what is my concern is the bonding for the parents. And psychosocially, do you see why I said that then?
Yeah.
Okay, makes sense? Not confusing too much, right? But again, you see, this is what we're looking at. So the lip repair, actually about 3 to 6 months of age, because it's not so extensive. A plastic surgeon comes in, they use a very staggered, very thin suture, and they stagger the suture, and it's very non-invasive. So that's why they do it at 3 to 6 months, because they don't have to be so. But now the cleft palate repair takes a lot of bone grafting, and takes sometimes multiple oral surgeons, ENT doctors, because they can also have some ear issues. So that's why they wait till they're more like 6 months to 2 years of age, because that's going to be a longer surgery. It's going to put them under anesthesia much longer. It's going to put them at risk much more. They have to graft bone from other areas. So that's why they wait a little bit longer with that. Whereas the lip repair, which again is all cosmetic, they can do very easily, sometimes even very minimal anesthesia, fairly quickly. And the younger they are, that they have something like that repaired, actually the less of a scar that will form. So that's why they say 3 to 6 months for the lip and later for the palate. People always ask me why later for the one than the other. Because the one is more invasive, more involved, and the lip is very easy, and actually they have better results. Infants, very young infants, have such regenerative cells that when they have an injury, or they can come with very great results.
And it says it's congenital, obviously, but is there a cause?
There are various causative agents, actually. Congenital, they're born with it, but what really, it's not genetic in nature. What usually causes it is something either the mother's exposed to in utero. So many times when there's drug and alcohol, again, going back to cleft lip, going back